Tell me why I don't like Mondays. Tell me why I don't like Mondays.
So tell me why I don't like Mondays. Well, love them or hate them, they're the start of the week, and that's a great time to think about new ideas. So welcome to this, a new series called The Perioperative Coach. In this series, we have top tips on all aspects of perioperative care from some of the world's experts working together to enhance surgical recovery. Don't forget to look on the show notes on topmedtalk.com for additional links to papers, etc. And of course, if you haven't done it already, subscribe to Top Med Talk. Top Med Talk. Urine output. Very briefly, do we have to still measure urine output?
Well, we do, and maybe not during the case, because intraoperative urine output has a variety of other issues related to it. I guess I wouldn't say don't measure it during the case, but it means something different intraoperatively. Perioperative urine output, though, is a vital sign and is strongly associated with adverse consequences.
But at the level, so the magic number is still debated, because there is some observational literature that says a little bit lower is probably okay.
Well, and I think what you have to say is that inferring numbers from an ICU cohort where the average fluid given to patients is 3 liters in the first day. It's the average. The mean is 3.2 liters in the first 24 hours and 2 liters per day after that is the mean. In a perioperative scenario, when you're trying to minimize, such as in colorectal surgery, where you're trying to minimize fluids, the amount of fluid that you may expect in urine output may be a bit lower. The human body needs to have a certain amount of urine output to excrete the solute load, but that's lower than the amount of amount of urine output that's necessary to excrete the volume that patients typically get. So if you're in an environment where you're giving patients less volume, you may be right that a lower urine output is a reasonable target. In the ICU, we're still at very high volumes, and therefore oliguria is still a very strong vital sign in that setting.
Tim, I think your institution in the post-operative period, you practice permissive oliguria. Is that right?
Absolutely. So we've analysed over 1,000 patients now where we've practiced permissive oliguria in our enhanced recovery protocol, and we've shown no difference in creatinine values compared to a previous cohort. And I think, aligning with what John said, we don't ignore...
But they're peeing, aren't they?
They are peeing. Yeah. They're peeing 20 mils an hour, for instance. But we don't ignore the urine output, but if the urine output is 20 mils an hour, the blood pressure is good, everything else is looking good, the patient says they're not feeling thirsty, this may be part of their normal stress response to surgery, and we wouldn't necessarily chase this with fluids. And frequently I find if you do chase this with fluids, you don't actually pick the urine output up, so your intervention doesn't actually help. Obviously, if there's another situation where they are hypotensive, the low urine output, and again, in that situation, it may be the right thing to do is to raise the blood pressure rather than actually to give fluid.
And that's a fully developed, enhanced recovery program. You've done the pre-hydration, you've done the goal-directed therapy.
That's a very important point. So all patients get goal-directed therapy. So we're fairly comfortable that they're leaving the operating room in a full state with a good stroke volume. So if they're in that situation, if their urine output over the next hour or two is a little bit low, we could be more comfortable perhaps in not intervening, particularly with fluid.
Well, and I think you said it exactly correctly. It's not that you ignore urine output. It's still an important vital sign. If somebody in this setting had a very diminished urine output, all of a sudden you'd pay attention to it, and you wouldn't necessarily treat it with volume. I think that's the most important thing, is that, like a tachycardia, which is another vital sign that we see frequently, the treatment isn't give a beta blocker. The treatment is to understand why the patient is tachycardic. And so I think what we're saying is that urine output is still an important sign to monitor. That doesn't mean that all urine output decrements should be treated with at all, and if they should be treated, they should be treated with fluid.
Top Med Talk.
Thanks for downloading and listening to Top Med Talk. Don't forget to find us on social media. We're on Twitter, Facebook, Instagram, even got our own YouTube channel. Whichever your favourite social media feed is, we're bound to be there. Find us. Also, subscribe to this podcast so that you never miss an episode. And make sure you go to the Top Med Talk website, topmedtalk.com. and get on board with the email updates. Oh, whilst you're at it as well, I suggest you download our entire back catalogue. We're categorising at the moment. We're having a little look through it. It may not always be in the form that you currently find it. So if you get your hard drive ready for a full-on download via the website perhaps, or perhaps through your podcatcher. Oh, and if you fancy meeting us, why not go to the website ebpom.org/meetings. Our next big event is EBPOM USA, the Dallas Masters Course, a perioperative care practicum. Have a look for details of that and some of the other meetings coming up across the next year. ebpom.org/meetings.